how to do maximum benefit of the patients with tuberculosis is extremely common in underdeveloped countries where malnutrition and overcrowding are the major concern. Diagnostic confirmation is a challenge as the patients usually presents us to very much late. Then this is the recent guidelines in 2026 when to suspect spinal tuberculosis. That is a persistent localized pain in spine region, more than 6 week night pain, associated with local tenderness, local deformity, and having neurological to us with 3-level disease, cervicodorsal, lumbar, and sacral, in a very much poor socioeconomic status. Because the patient's walking child of 2 years suddenly stopped walking and the pain again 6 months after. And patient is taking some practice. We all know that large number of patients with the stable spine responds well to the ATT. And this is the paper published when, particularly in the soft acute spinal tuberculosis, we can remove from this spinous process to ribs and pedicle and whatever body to put anything, bone graft, case. And here are the few cases where there is extensive vertebral body dissection and we have put the cage and patients recovered well and getting the fusion surface. But here the fusion surface is very much deficient when you do your major surgery. Then why not to think surgery for acute spinal tuberculosis should be limited, bone preserving, muscle preserving. These are the few examples. We do only the laminotomy and fixing and patients has the good results. We are usually inserting the bullet cage when the disease in such a way that there is a strong bone in cases of tuberculosis to hold that cage. And sometimes we debride and put the bone graft. At opposite side of the bed, we reserve for the bone grafting. We remove the blood and we reserve for the bone grafting. So after bone preservation, why not to preserve paraspinal muscle also? We all know. And this is the Pott's spine D11, D12 surgery. And we are now practicing the window techniques. In fact, we have the 5 window techniques to put pedicle screw, rod and decompress. This is central window. So this is our picture of doing spine surgery at present. No maximum bone removal, no maximum muscle damage, and the patients start working after 3 to 4 days of surgery, and we rely still on the anti-tubercular drug to heal the disease. Thank you very much for inviting me.
Thank you, Dr. Pandey.